I would like to announce now Nicolas Thurin, who will be chairing the next session. Nicolas is a scientific director at University Bordeaux, and was a very active participant in the CVM project and many other projects. So thank you, Nicolas.
Thank you very much, Miriam. So I'm very pleased to open this session on readiness of data sources. So we'll mainly speak about fit-for-purpose assessment. Miriam asked me a long time ago to chair this session. I just tried to thought what that means for me, fit for purpose, and I had like a picture that came to my mind. It's when you want to fix a screw, but you don't have the good screwdriver, so you try to use your knife, which is not really fit for purpose. Most of the time you break your knife, and you are not much advanced after that. So that's really the topic of today. It takes right tools to be a good handyman, and it's also need like right data sources to make good science and to address directly the question. So our first speaker today will be Carlos Durán, who is assistant professor at the University Medical Center of Utrecht. And Carlos will speak about whether the data source of the COVID-19 vaccine monitoring project was fit for purpose. He will support that with the demonstration of quality check and also a comparison with the vaccination uptake tracker of ECDC. Carlos, adelante.
Yes. Well, thank you. Well, I go straight away to my presentation. A bit of disclaimer that also helps me to explain you a little bit of the organization of this project. This project was led the scientific work by UMC Utrecht. Hviid coordinated project management, and analytical scripts were developed by Ars Tuscany and Utrecht University. What I'm going to try to explain you is about what we aim in the readiness phase of CVM, what databases were included, the steps taken to produce results, a few examples, and then I will stay a bit more time on the fit for purpose assessment of the readiness phase. So what were the aims of the readiness phase of the CVM project? Were first of all to create and assess the readiness of electronic healthcare data sources for rapid evaluation of safety signals by providing an overview of the methods to identify COVID-19 vaccine exposure data sources, to monitor the number of individuals exposed to any COVID vaccine and to compare this to COVID-19 exposure by the ECDC tracker, and also to generate updated background rates for adverse events of special interest. I mean updated from Access project. So these were the databases who were included, and please let me mention every single database. So first were FARMU from the Netherlands included, then BIFAB, FISABIO, and CIRIAF from Spain, Pedianet, ARS, and Caserta from Italy, and CPRD from UK, but provided by Utrecht University, and also Norwegian health registries from Norway. Unfortunately, in the beginning, also LASIO data from LASIO was planned, but at the end, due to data accessibility problems, at the end was not contributing data to this project. So what the steps we take? First of all, data sources, so data access partners, prepared the ETL design for transformation their local data into the conception common data model, who was the model we use in this project. They all ran the quality checks as the framework of the quality control framework of the CDM, the conception CDM, and they also ran what we called the additional readiness assessment script that includes the vaccine uptake characteristics of vaccinated people and incidence rates of 39 ISIs during 2019 and 2020, pre and post-COVID. So this is the general overview of what the conception common data model, how it looks like. I will not go deep into it. And these are the general overview as well of the quality check, of the quality control process of the CDM from level 1, the coherence and completeness of the data, till study-specific data content characterization. So all data access partners and all data sources went through every single step or level of the quality check process. This is just to show a bit some examples of the quality check. That you cannot really see it, but just to show that the kind of outputs we get with quality checks. So we can just push one of these or click one of these lines, and then we can see trends. So every single quality check is reviewed, or it's independently reviewed by a reviewer. And then when it is passed, we have a form that is signed by the reviewer and the data access provider. So what about fit for purpose assessment of the CBM? First of all, of course, the first step is to pass all the quality checks, as explained. Then we had the benchmarking exercise of vaccine coverage against the ECDC tracker. Then the heterogeneity evaluation by provenance. And finally, this is work in progress, but I will present some of what we're doing right now is the data feasibility assessment as proposed by Nicolas. So this is the benchmarking of vaccine coverage against the ECDC. I will show you every single database, but here you see in orange, let's say, and then in orange the ECDC, and in red the data from the project. And they fit very well, and they go along quite good. This is for Norway. This is for Farmo. You have some distance here, but in general, you can see that they go together very well. This is for Spanish databases, CDApp, FISABIO, again. There's some difference here as well, but the figures are similar. For BFAP, for Ars, Italy. And then also for Caserta and Pedianet. Here in Caserta you can see that there is some difference in time, but again the shape keeps the same, let's say. So this is the other step, the assessment by provenance. This is a table taken directly from the report. You see here a few examples of the ISIs and what were the criteria we used to evaluate this. So just let's take an example. With acute kidney injury, we evaluated the comparison against access and other literature mainly access and other papers published already. What was the effect of lockdown? What happened with COVID-19 infection? So in the case of acute kidney injury, the lockdown decreases the rates, but the COVID infection increased the rates. And finally, the evaluation by provenance. So you can see that there's an underestimation when you use GP only and hospital only, and then the rate is highest when you combine hospital and outpatient data. And for this particular event, Norwegian, Caserta, and Farmo instances are not fit for purpose for this event. And then the evaluation by Nicole Gatto, as I said, this is work in progress. They presented this data feasibility assessment framework I think a couple of years ago. With three main steps. First of all, they proposed to operationalize and rank the minimal criteria to answer the research question. We are talking about databases. Then identify and narrow down the data sources option, and finally conduct a detailed feasibility assessment. So I'm going to present next slide this work that, as I said, is preliminary work. So I just bring a few examples of certain ISIs. Here you see the different databases, and this is a heat map with 5 being the best and 1 being not fit for purpose, let's say. So what we can see here is that, for example, here in anosmia and aheusia, which is an event that you can find mainly on GP databases. For example, Pharmo becomes very good one, 5. No? But in other ones where you need really hospital data, then Pharmo becomes 1 because there's no hospital information in. No? And then you see that in most of the cases we have 4, 5 no? as the evaluation. We have here another kind of what happened with vaccine coverage, the length of follow-up and data recency. You can also evaluate this under this framework, and also you can evaluate the timeline that you have for having the data, the time lags, and also even contracting logistics. If this is good or low means good. So I didn't want to, at the end of the day, put it here, the final evaluation, because at the end of the day, what we conclude is that depending of the evaluated ISIs, some of them would not be fit to participate in evaluation studies using the current instance due to misclassification of ISIs. So it can be that if you want to evaluate aheusia, then you have Pharmo as a good option. But if you want to evaluate, coronary artery disease, then it's not a good option. So we cannot take a final decision here like as a unique thing. So this is the first conclusion, and then we have in CBM, data sources are fit for purpose as regards population and vaccine coverage. And also, misclassification is strongly dependent on the type of databases used by data sources. For instance, if this GP only, or emergency room, or outpatient visit, or hospitalization only. No? The meaning of the codes, if you use primary or secondary discharge diagnosis, and also if you use narrow or broad event definitions. So, as a final take-home message, depending on the healthcare settings where a given event is diagnosed and treated, and the provenance of the data bank, a data instance may or not be fit for purpose. So this is, I think, my last slide. No, this is my last slide, just to say a big thank you to all of you and to all the partners who participated in this project. And remember that the final study report is already publicly available and openly for everyone in Zenodo platform. And thank you for all the efforts. Thank you.
Thank you very much, Carlos. Do we have any question in the audience? Vera has a question.
Helpful for all of us doing studies going forward. Just clarification, when you had the table and you said some rates were overestimated, some were underestimated, what was the actual benchmark? Because you had the access database and then you wanted to, so was that your benchmark then, when you said,
Not only, but I would say 90% of the cases it was access. Because there were some slight differences between access and TBM. So not always we could evaluate against access, but in most of the cases, yes.
Okay.
Yeah.
Thank you.
Thank you, Brad.
Any other?
Thank you. This is a very critical work for the quality of what we're trying to do with using database for studies. Now, I had the same question. So your benchmark is a critical choice, and you have selected to compare to another database study. Maybe you're using the same database. Why not going to lit review or primary epi studies who had measured incidence of specific disease? That's one question. And the other question that's a bit related to that is, for example, for the coverage, there are differences in the coverage or the timing. However, at the end, you put 5 to each database and maybe a 4. So it means you have been satisfied and the test is okay, but how much did you allow as a difference between the coverage from the ECDC tracker and your own database? How have you decided that 1% or 10% or 5% is acceptable? And do you know what the impact would be on any study?
Thank you. Well, regarding benchmarking, I think, yes, the proper way to do it should be to do a proper review. It was about time and the amount of resources we have. And of course, we already performed the Access project, so we want really to compare it, and Access project was performed under more or less the same methods. So it was nice for us to compare against Access, but I agree that having more time and a proper project for aimed to compare and benchmarking should be done under a more wide framework of evaluation. I agree. And regarding the benchmarking against each CDC tracker, I don't really have an answer for that. I don't know if you, Miriam, or Frosa, I don't know.
This is not the source of the benchmarking. It's how much do what difference do you find acceptable, and how do you define that? I don't know, a 5% difference in your coverage and ECDC is acceptable. It makes you put a 5 to that database.
Yeah, I know.
Maybe just to comment on that, because I think the ECDC data are also not perfect. So they are also coming from somewhere, and for some countries they have just been the amount of doses sold or shipped or whatever. So it's the benchmark is not always perfect. That's one of them. But what I think was really good to see is that the timing actually was very much aligned. So I think it's impressive. And then also we need to take care of that some of the databases are not national, like for example Catalonia. These estimates are always national, so there can be some difference. But I think all in all, it was actually quite impressive to see it, the ships so aligned.
Thank you.
Thank you.
So not a question, but just on the last point, it's important data also for us to see the alignment with the CDC data, especially as the tracker is somehow stopped. And it also gives, and this morning in the discussions that I observed to expected when we said we need a lot of granularity also for vaccine coverage, we know we could probably have more granularity using this in case we need them in the future.
Thank you, Karim.
Thank you. We have space for a last very short question from Ron.
Is that typically for COVID, you are very dependent on the timing of the diagnostic coding, which is actually here very important, because some people might know, for instance, in our database, we know who has acute kidney failure, but the comment is right that we don't know when it happens. And I think for pharmacoepi, it's very important to have a very fixed and good timing variable in your database. That's just what I want to comment.
I totally agree, and this is one of the challenges that were mentioned by Miriam in the opening session this morning. The misclassification of outcome is an important challenge in this kind of studies. Yeah, totally agree.
Thank you very much, Carlos.
Thank you.
We'll now welcome to Anders Hviid. Anders is professor and head of the Department of Epidemiology Research at the Statens Serum Institute. He leads vaccine study for the Nordic collaboration and conducted studies on myocarditis, autoimmune disorder following COVID-19 vaccination for the EMA. And he used Norwegian, Finnish, Danish, and Swedish links registry data. Welcome.
Thank you. I was a little bit confused by this concept of fit for purpose, I must say. And I was a little bit stressed out by having to fill 10 minutes talking about fit for purpose in relation to the Nordic register data. I'm almost tempted to just say fit for purpose. It's designed, almost designed for purpose, right? And end the talk here. But let's try when I get some slides. Yes. So, many of you will, I hope, already be familiar with the Nordic countries, the fantastic Nordic registers, 4 countries have contributed to this collaboration. There are other Nordic countries. These are the 4 larger Nordic countries. So if there are any people from Iceland here, don't be offended. Denmark, Finland, Norway, around 5.5 million each country. And then we have our big brother Sweden, who is over 10 million. So during the pandemic, we've been able to do like studies of in excess of 20 million. And the study we've done on vaccine safety in the context of EMA was in children, and there we were able to do a 5.1 million combined cohort study. So you can see here the key data sources are nationwide registers, right? Nationwide immunization register, a nationwide hospitalization/outcome register, and then a demography register. And actually also when we do COVID-19 related stuff, we actually also need a COVID-19 database, right? We also have those nationwide microbiology database. What's really great about these nationwide registers is that they are also quite similar across the countries, right? So we are immediately compatible. So it's basically just plug and play. And yeah, nationwide, everyone is in these registers. In the demography register, we have a unique identifier. When people get vaccinated, they are in the vaccination register. When they go to hospital, they're in the hospital register. I don't know what more to tell you here. It's dates, it's ICD-10 codes. What's special about our approach also here is that we are the national competent authorities, especially in the context of COVID-19, from Denmark and Finland and Norway. We were the authorities responsible for COVID-19 related surveillance and prevention. And from Sweden, we had the Swedish Medicines Agency participating. And being the national competent authorities also in this field means that we are the data owners of many of the gold standard registers that are used, right? So I mentioned the microbiology database. So it's the official sort of surveillance database for COVID-19 surveillance in Denmark, talking about Denmark. So it's the data that provides the numbers for the government, the numbers for the national official dashboards. So there's really nothing else to compare with. That's the data that we've used, and that's the gold standard. So there's a one-to-one match there. And again, we saw from the last speaker a comparison to the ECDC tracker of vaccination uptake. But again, we are working with the data that is used to provide these information for the tracker. So, I mean, there's really nothing to compare. It's the same data. So I guess it's fit for purpose in that way. Another great thing during the pandemic has been the fact that we've had real-time access as national competent authorities. I see some of my national academic colleagues, they haven't had the same real-time access. So they've had to queue up to get access to the data, while we've had the privilege of having more or less real-time access, meaning data that's updated on a day-to-day basis, right? Yeah, so it's the gold standard, people. Again, I cannot elaborate much more on that, but I have to. So, with respect to the vaccine uptake, the study that I mentioned before was the study on myocarditis and other safety outcomes in children and adolescents in the Nordic countries. These are some of the vaccine coverage data. what you can see here is that there are some differences across the countries, at least with respect to the uptake, which clearly reflects the difference in national recommendations. The fact that Denmark, for example, had general recommendations for 5 to 11-year-olds, which none of the other Nordic countries have. And perhaps in general, we've had a little bit of a higher uptake. So that's also reflected here. You can see that in the 5 to 19-year-olds in Denmark, 65% actually received at least one COVID-19 vaccine. And what we can also see from these figures and numbers is that the winner, the favorite vaccine, the most used vaccine was the Pfizer-BioNTech. Yeah. I can say a little bit more about the outcome registers, of course. I think we can all intuitively understand that they are fit for purpose for studying the outcomes that you would expect are being recorded in a hospitalization register. And these are hospitalization registers that cover hospitalization contacts. So in Denmark and the other Nordic countries, this means inpatients, but also outpatients, ambulatory care, and emergency department contacts. Yeah, and yeah, what can I say? So we don't have primary care. There's always this issue of symptom onset in these types of registers. We only have the date of diagnosis, right? So we have to think carefully: is this a date that is good to use in our studies, or are we looking at outcomes that have a more insidious onset, right? Where we have symptom onset that develops and then maybe takes a long while before we get into the clinical setting and get a diagnosis. No primary care, I said that. This was also part of a feasibility study looking at immune-mediated outcomes. And one part of that was not to only look at new onset disease, but also to look at disease flares in cohorts of children with already existing immune-mediated disease. And so there we look at our vaccination associated with disease flares. Again, we don't have that directly in the registers. We have to use a proxy. We have to look at recordings like our visits at hospital, for example, outpatient visits with immune-mediated disease diagnoses in a cohort of children with immune-mediated disease. Are they good proxies for disease flares? No, not. Yeah, well, maybe it's the only proxies that we have. They're not perfect, at least, right? But that's the only. I think it's basically the only option we have if we want to do something with rare immune-mediated diseases in a large setting. We're going to talk a little bit more about myocarditis later today, right? And again, with respect to validity of the different outcomes, it's on a case-by-case basis. Myocarditis in less than 14-year-olds in Sweden, actually, recent validation study, a positive predictive value of 96%. So I think that's okay. There's also a large history of research that has been done on the Danish registers and the other Nordic registers. A lot of validation studies. So it's easy to go and do a literature review and check, is this outcome fit for purpose to study in these registers, right? And a lot of the thromboembolic stuff, I mean, there is a bit of a challenge in looking at it in children and adolescents because we don't have specific validation studies there, but at least in adults we have validation studies that has been done and show that they're fit for purpose, right? Stuff like type 1 diabetes we also have for children, and they're fit for purpose. Is that it? It's frozen? Nope. Okay. Yeah. And so, yeah, what my recommendation is, of course, be sensible, case-by-case basis, do a literature review, check your background rates in the data, do they look sensible? Yeah, the conclusion here is that a lot of these outcomes are not only rare in children and adolescents, they're very rare, right? This is on a logarithmic scale, and I'm pleased to see that pulmonary embolism is like more rare than 1 in a million, right? Person years. So that seems reasonable. Yes. Conclusions. Yeah, it's fit for purpose, I would say. Yeah. I mean, yes. Yeah. So,
Well,
but of course there are a lot of outcomes that are not fit for purpose to study in a register. We heard about AGUs here. We've heard about patient-reported outcomes, right? So there's a lot of stuff that we cannot do also.
Thank you very much, Anders, for this enthusiastic presentation on fit for purposeness, which is the right topic. Any question? Ron has a question.
Well, thank you for this funny presentation. Actually, probably you are not so lookalike in the Nordic countries than you suggest. Otherwise, you would not live in different countries and you don't have different languages. And you do have different reimbursement systems, and you do have probably different ways of vaccinations, of distribution of drugs. So I would rather fight against the idea that it is always fit for purpose, because it depends actually also how you do the same things in the same country, which is probably not what it is. Do you have any idea how that affects the outcomes? Is it indeed so? Is that the validity of hospitalization for myocarditis in Sweden, Finland, and in Denmark is the same, or could that be different? And is the availability of particular vaccines in order of vaccination in the countries the same?
No. Okay. No, I'm sure if we put the clinicians into a room together, for example, the cardiologists, they could find differences, right? So our approach has been, so we're doing meta-analysis, right? So we're doing the country-specific analysis and then combining. So I think that as long as it's internally valid within countries, I guess it's...
Yeah, well, the suggestion was actually that it is a push on the button, which is not actually.
Sorry, I didn't...
It's not a push on a button, it's actually more than that to do it.
No. No. It's you still have to think. But I mean.
Unfortunately.
Any other question in the room? Okay, well, thank you. We are reaching the 15 minutes. Thank you very much, Anders. So I must apologize for the little trick I did with the schedule. So the next speaker will be Katia, who will be connected online. Sorry, Katia. So Katia is Associate Professor in Observational Data Analysis from Erasmus Medical Center. She used data sources from IQVIA, CDAP, and CPRD for the study on thromboembolic events for the EMA. Thank you, Katia.
I'm not sure whether you can see me or...
We can see and hear you perfectly.
Okay, great. With regards to... okay, and I'm... Okay. Good afternoon, everyone, and sorry, oh my God, I have an echo. It's better now, or not?
Yeah, we are hearing you perfectly, but not seeing the slides yet.
So I can perhaps start to apologize because...
so you need to share your slides, right?
I need to share?
Yeah, you should share your screen.
No, sorry. Okay. You see the screen, you see my slides now, I think. Or not? Can you still hear me?
Yeah.
Do you see the slides?
Not yet, but it's our fault, not yours. It should be okay now. We see it. Can start.
Okay. So good afternoon, everyone, and thank you for inviting me. And sorry that I couldn't make it in person, but I have a terrible cold, COVID negative, but that's not important, of course. But yeah, traveling to Utrecht was difficult. Can someone move it to the next slide? Okay. So I'm going to give you a little bit history about the study that we did. So we had submitted, we were one of the preferred partners for Lot 3, Rapid Descriptive Studies. Can you still hear me? Or can you still hear me? Okay.
The mic has, yeah, but see, yes.
Okay. So we were one of the preferred partners for Lot 3, Rapid Descriptive Studies, and then in 2021, there was a launch or a request to study the association between thrombosis with thrombocytopenia syndrome or thromboembolic events in COVID-19 vaccines. The data sources that we had within our original consortium, they were already all mapped to the OMOP Common Data Model. And the OMOP Common Data Model, you can see the slide here. So you're familiar with that, but I quickly go through it. On the figure, you see 3 source databases, which are heterogeneous in data structure and use different vocabulary. And these are mapped to the OMOP Common Data Model, which ensures that they have a homogeneous data structure and that they use one common terminology or vocabulary. And this allows that analytical codes, which are written for a specific research question, can then run on the data, of course, in a federated manner, and that the results are shared with the coordinating center or with the principal investigator to explore the results and draft a report. Can you go to the next slide? So what we did with regard to this study which came in, so we looked into our databases from our consortium and we organized them in the following way. So we had primary care databases, for instance, CPRD linked to hospital data. We had, for instance, CDAP also linked to hospital data. We had outpatient databases, including primary and ambulatory specialist data. We had health claims data, so we had claims data from the US, hospital electronic medical records, so US hospital record and Barcelona hospital database, and we had UK Biobank. So we had the geographic spread. We looked into the number of individual or active patients at time of the study request in 2021. And then we checked whether these data sources had key data, which was responsible to, or which was crucial to answer the question. In particular, do they have information on COVID vaccines by type of COVID vaccines and whether coverage was complete? And you see that in the column where we had complete first to incomplete coverage. Perhaps also good to mention that for CPOD Gold in 2021, this was incomplete, but now because of the UK vaccination registry, CPOD Gold now has complete coverage of COVID-19 vaccines. We checked whether the data sources had information on hospital treatment, hospital outcomes, whether we had information on outpatient treatments, and very important as well, so the outcome was thrombocytopenia with thrombosis. So it was important for us not only to consider disease codes for that outcome, but also to take platelet counts into account. So having information on platelet counts within the databases was important. Next slide. If we consider sources within our consortium and the fit for purpose question, as I said, so the source data were mapped to the OMOP Common Data Model, and there's already a quality check quality evaluation, which is done at that time, at the time of mapping. So we have some tools, some Odyssey tools, and the first one, which you can see here, it's a high-level data quality check. It's called Achilles. It's an acronym. And what it does is it's going to give you some visualization, characterization of the database which have been mapped to the common data model. So on the figure which you see here, it's a little bit small, but it's a synthetic data set, and it provides you the distribution of birth year of the individuals enrolled in the database, and then also, for instance, distribution by gender and ethnicity. Another tool which is used as part of Odyssey and as part of mapping is the data quality dashboard. And what the data quality dashboard does is it goes table by table and field by field. It's going to check whether the number of records in the common data model that do not perform to given specifications. So you had defined upfront a specific threshold, and that data quality dashboard is going to check, for instance, how many individuals do not have information on the sex, on the birth date, and so on. Next slide, please. So these were high-level data quality checks, but we can also do individual-level data quality checks, and again, irrespective of the research question. Mapping to a common data model can be complex, and so you might be interested to see, for instance, whether specific mapping from source to common data model went well, and this can be done by tools, and this specific tool that you see here is rabbit in a hat. That by itself is not that relevant, but what it shows here, what it explores is how gender, for instance, is coded within the source data and whether that mapping went well when source is mapped to a common data model. So these are quality checks which are done, but irrespective of the research question. Can you go to the next slide, please? But so here we were in a situation where we wanted to explore the safety of COVID-19 vaccines. So we were doing study-specific checks. And so in view of the research question, so the first thing that we explored was the geographical spread, and I've already described that in the table that you see at the right, and that I described in the beginning. And what was crucial, apart from the geographical spread, is whether we had information on COVID-19 vaccines and the coverage, and whether we could differentiate by type of vaccine, for instance, and then whether we had relevant information, which was important to explore the outcomes of interest. So, and also how these outcomes of interest were treated. So do we have hospital data, and do we have information on platelet counts? And then we did some specific quality checks, and we used Odyssey tools for that as well. Perhaps good to mention that two of the databases that we were initially thinking of considering, namely the Royal College GP registry, they did not complete the mapping in time, and we didn't have the data quality checks in time. So that database was excluded from the analysis, and CPOD Gold mapping was not available in time. So these data sources could not be used for the study. Then we used the specific quality tool, so we ran cohort diagnostics on our data, and we did cohort diagnostics not only on the vaccination cohorts, but also on the outcomes. We call also the outcomes, they are called cohort, and cohort diagnostics ran on the exposure, but also on the outcome. Can you go to the next slide, please? So what does that cohort diagnostic? So it's a very valuable tool, very relevant tool. So it's going to provide you counts, how many people are within these cohorts, so the cohort of people being vaccinated, the cohort of people with the outcomes. It also provides incidence rates stratified by age, sex, and calendar year. So incidence rate of vaccine exposure, but also incidence rates of the outcomes, for instance, the thrombosis with thrombocytopenia. It also has as advantage that it gives you or provides you information on the concept IDs which were used to identify vaccination cohort or the outcome cohorts, and it also provides you information on potentially missing codes so that you can refine your cohort if important concept codes are missed. provides information on the healthcare setting at time of vaccination or at time of the outcome. It provides you characterization, so a description of characteristics of baseline patient features for the COVID, for the vaccination cohort and the outcome cohort. And then you can also play with specific time windows. So you can evaluate this at time of index day, but you can say, I want to redo this in the 30 days before, a year before. It has also a visualization of cohort overlaps. Then you can see the individuals within the vaccination cohort and the individuals in the outcome cohort and the percentage of overlap, for instance. And then as a nice tool as well, it can give you a comparison of characteristics of different cohorts. And I have a figure on that in one of the next slides. Can you go to the next slide, please? So this is, of course, if you run the cohort diagnostic, we receive a lot of data, and it's difficult to digest, but we have access to Shiny apps, which makes it easier to export the data. I'm now, so here you see a screenshot, not everything, of one of the Shiny apps. So here we're looking at CTAP data, it's on the vaccination cohorts, and it provides characteristics, for instance, proportion of females within the vaccinated cohort, whether they had COVID-19 in the previous year, and then some comorbidities, prevalences of comorbidities of interest. We have that for the not only comorbidity but also for medical, so concomitant medication of interest and so on. Can you go to the next slide, please? And then this is one of the things that I just described. So here we can compare characteristics of different cohorts. So for instance, this is a result for the CTAP database, where on the x-axis we have the AstraZeneca vaccine, and on the y-axis the people being vaccinated with Pfizer-BioNTech vaccine. And the nice thing about these figures is that it shows the characteristics. So these individual dots, they represent comorbidity, drugs, measurements, observations, and others. And so what is nice, sorry, see myself. So what is nice about this figure is that it compares the distribution of these different conditions between the different cohorts, and it already gives you an idea on the potential differential prescribing, for instance, providing insight in the need to control for that. Next slide. So with regard to the fit for purpose, so the first quality check that we have when we map our data to data model is that we do high level and individual data checks. And then irrespective, so if we then move to the research question, then we're going to select data sources depending on the research question, identify which databases can answer which study objectives, and study objectives, either all of the objectives, or we can also select specific databases for part of the objectives, for instance. And then the most important part is to start exploring the cohorts, the exposure cohort and the outcome cohort, so the people being vaccinated and the people with the outcomes of interest, where we're going to check for completeness. Is there a potential of missing codes? We're going to explore cohort characteristics, and then also do a benchmark of instance rates. I think that was my last slide.
Thank you very much, Katia. Thank you very much. Do we have any question in the room? Yeah, Rosa, Miriam.
Thank you very much, Katia, and I'm feeling sorry for you that you feel so ill. You can see it. So I never understand what exactly is on that diagonal graph, like when you do the cohort diagnostics, and you were explaining it. But so what? So a dot is a condition, I understand, a separate condition.
Yeah, and it can be. So it's either proportion, or it could be. So it's a proportion for binary. For instance, for comorbidity, it might be COPD, no COPD, for instance. So then it's going to give you the proportion of people with COPD in the AstraZeneca cohort versus the Pfizer cohort, and then you see whether there are differences in proportion or different. And so it might be continuous variables. So then it would be the mean for blood pressure or cholesterol level, and you can see whether you have differences in distribution of comorbidity measurements, use of concomitant medication, and it gives an idea on differential prescribing and whether you need to control for that.
Okay, so you can actually, within a database, you check the different cohorts. And do you measure then against like the year prior? Is there a fixed look-back period? Or?
So you can play with that. You can say, I'm going to look at the index data and say a month before, a year before, And so you have a Shiny app. I didn't. We have a link to the Shiny app, but I just put screenshots. But if you go to the Shiny app, you can play around with that, and then you see different visualization, and that's a nice thing. So it's a very powerful tool to explore your data and to see whether there are potential issues or concerns.
Okay, thank you very much. And do you benchmark against external benchmarks, for example, the vaccination, like?
Yeah, I think we would do. We would benchmark across data sources, but also beyond. Look into literature and see whether it makes sense.
I've also a question. So in the quality pipeline of Odyssey or MOP, so you have all the quality assessment at the very beginning, aligning the standards and the source vocabularies, and then the data quality dashboard and everything, and then you have your cohort assessment. But do you specifically assess the alignment between source and standards vocabulary in the framework of a specific studies?
So you would, in principle, if your data is mapped, you would assume that this has already been done. But as I said, it might be that you're looking for specific conditions or outcomes, for instance. And then it might be that you dive into the individual situation, and that you're going to look what is the source code and how has this been mapped. And I think this happened also around what happened for the COVID-19 vaccines. For instance, COVID-19 was a new condition, so there was not yet a mapping, and then activities were done on mapping from source to mapped the OMOP common data, mapped to OMOP common data model. So it's a continuous process. So in principle, we assume and we know that data quality went well, but we might have specific research questions where we go back to the source data and that we're going to evaluate the mapping and how this was done. If we think that there might be a concern, that's something that we're going to do.
Well, thank you very much, Katia. We have one last question from Gianluca.
Hi, Katia. Nice to meet you.
Hi, Gianluca.
Regarding the selection of the databases for addressing clinical research questions, you mentioned that, of course, not always we can use all the database to address a specific question. So I wonder if there is a way to select in an objective way the databases and a priori, or is this based on a cohort characterization? When this happens, and is it possible to make it objective, the assessment, to have kind of objective automatic selection?
So what happened in this situation is we had our consortium already, so we were part of the partners, preferred partners for the framework contract, with a list of partners, but then we checked, can these data partners provide the information that we need? So the inclusion as potential data partners, that was done based on the characteristics and the fact that they were mapped. They were already part of the consortium, but then we had our specific question, and then we dived into, do they have the information that we need to answer the question? For instance, do they have, like granularity of data? For instance, IPSI, it's a very valuable data source, but not always very granular. So it might be that for certain outcomes, it's not the perfect database. So yeah, I think all of us, when we select our data partners, we're going to select the data partners where we think they are most suitable to answer the question based on the criteria, like what data do they have? Can they answer the question? So I think that's it done in an objective way. Yeah. And Januka doesn't agree.
Well, perfect. Thank you very much, Katia.